Good morning, everyone. It's my pleasure to welcome you to the final university rounds for the Department of Surgery for this academic year. I'm Carol Swallow, and I'd like to say thank you to all of you who are here in person at Sick Kids in the Hollywood Theater, and those of you who've joined us online as well. It's really a great pleasure to have an illustrious visiting professor joining us this morning to deliver the tile lecture. And we all welcome Deb Stein, who's going to be introduced formally by Morgan Schellenberg, who will take over the proceedings just shortly after I'm done here at the podium. I would like to begin by acknowledging that the land upon which the University of Toronto operates has for thousands of years been the traditional homeland of many Indigenous peoples, including the Haudenosaunee, the Huron-Wendat, the Anishinaabeg, and the Mississaugas of the Credit. We would like to also acknowledge the historical injustices done to these people over millennia and certainly up into the present time. And we would seek to do better in our relationships with them and with this land upon which we meet today. So with that, I'm going to turn the proceedings over to my colleague, who is a trauma/ACS surgeon, mostly trauma surgeon at St. Michael's Hospital, Unity Health in Toronto, Dr. Morgan Schellenberg. Morgan, thank you.
Thank you so much, Dr. Swallow, and thank you to all of you for being here this morning. This lectureship is named in recognition of Dr. Marvin Tile, who served as surgeon-in-chief at Sunnybrook from 1985 to 1995. He was a world authority on the treatment of pelvic and acetabular trauma, the past president of the AO Foundation in Switzerland, and was appointed to the Order of Canada for the contributions he made as a surgeon, educator, and innovator. He also played a pivotal role in developing the trauma program at Sunnybrook and in organizing trauma services across Toronto, helping to shape the collaborative trauma services at the University of Toronto across our 3 trauma centers, St. Michael's, Sunnybrook, and Sick Kids. His impact has touched many of us through his wisdom, mentorship, and philanthropic support of academic surgery. Sadly, this is the first Tile lecture since its establishment at which Dr. Tile is not with us following his passing last August. I would like to recognize the members of Dr. Tile's family who have continued their engagement with the Department of Surgery. We are thrilled to introduce our 2026 Tile Lecturer in Trauma, Dr. Deb Stein. Dr. Stein is a professor of shock and trauma at the University of Maryland in Baltimore, where she is a trauma surgeon and intensivist at the well-known Shock Trauma Center, one of the busiest centers in North America. She's the Associate Director of Academic Affairs for the program in trauma at the University of Maryland School of Medicine, as well as the Director of Adult Critical Care Services for the university. She's authored over 340 peer-reviewed publications with research interests focusing on patient-centered outcomes in the fields of traumatic brain injury, hemorrhagic shock, geriatric injury, and functional outcomes. She holds or has held significant leadership titles in all major American trauma societies, including being the recent past president of EAST and the immediate past chair of the Algorithms Committee of Western Trauma. One of the things I admire most about Dr. Stein is that in addition to her contributions to academia, she's a truly outstanding clinician. I had the opportunity to work with her as a resident on elective back in 2014, and it was the first time I was really exposed to surgeon intensivists. In the middle of rounds in the neuro ICU one Saturday, she said she needed to leave for a bit. She returned 90 minutes later, soaked in blood, and without saying anything, just returned to her rounds. I found out later she had assisted a junior faculty member in performing a trauma pneumonectomy on a young man who was injured in a motorcycle collision. Watching her seamlessly flow between being a trauma surgeon and being an intensivist was very inspiring and motivating for me as a trainee, and she remains a role model for trauma surgeon intensivists. Lastly, I hope she won't mind me adding that in addition to her clinical research and leadership skills, Dr. Stein is a wonderfully kind human being with a sharp sense of humor and an uncanny ability to form communities around her. She's truly one of the greats. So please join me in welcoming Dr. Stein for her 2026 Tile Lecture in Trauma, where she'll be discussing the contemporary management of traumatic brain injury. Dr. Stein.
Well, Morgan, thank you for that very embarrassing, but very, very kind introduction. And thank you so much for the invitation to be here. I can't tell you how honored I am. And I'm very sorry that Dr. Tile is unable with his recent passing to be here with us, but it's really a privilege. It's funny because I come from the land of the Burgess classification of pelvic fracture. So that being said, it is really, truly an honor to be here. I have no relevant financial disclosures, but I will tell you, I'm actually really nervous about this. It's Avery's fault. So he's not here, so I can say that out loud. He's like, well, it's gonna be a really wide range of people who are gonna be there, from like medical students and residents and people who don't know anything about trauma to like the chairman of the Department of Neurosurgery, who I think is here. So hi. So what I tried to do is put together something that would be relevant for everybody, but I may have missed the mark, so I apologize in advance. This is all the things I'm not gonna talk about. I could talk about traumatic brain injury all day, every day. I could bore you all to death with all of these things that I'm not going to be talking about. So what I want to do today is talk a little bit about some practical aspects of how we take care of a patient with brain injury, largely as it relates to the first 12, 24 hours. I'm not going to get into like management of vasospasm subsequently and post-traumatic seizure management and rehabilitation, and then come to go through a little bit of it's like kind of new stuff, because really there hasn't been a big evolution in traumatic brain injury care over the last 15, 20 years, but there's some actual kernels of things that are highly relevant that aren't necessarily specifically brain focused. So I'll get into that towards the end of the lecture, but apologies to the non-trauma surgeons for the gross pictures, but we're trauma surgeons, that's what we do. We show gross pictures. But one of the reasons why I would invite you to come care about patients about brain injury with me is that it is a huge public health problem. Traumatic brain injury is the leading cause of death following injury. So people think that hemorrhage is the leading cause of death. Hemorrhage is actually the leading cause of potentially preventable death, but traumatic brain injury is actually the leading cause of death, with sepsis and multiple organ dysfunction being number 3. And we know that people who suffer brain injury are at if they survive their brain injury, they are at increased risk of depression and PTSD, and increased risk of suicide, and increased risk of substance abuse. Survivors of brain injury are at a 3 times greater risk of experiencing a second TBI and an 8 times greater risk of sustaining subsequent other injuries over their lifetime. And then this statistic is terrifying. Estimates of 60 to 80% of people in prison currently have a history of traumatic brain injury, which is compared to 8 to 15% of the general population. So establishing kind of this association between criminality, which is and previous history of traumatic brain injury. We know that brain injuries can affect anybody at any point of their lives. However, there are certain individuals who are at increased risk of long-term sequelae from those brain injuries. And those are classically our very vulnerable populations: racial and ethnic minorities, service members and veterans, people who experience homelessness, people who are in correctional and detention facilities, survivors of intimate partner violence, and people living in rural areas. So just this disparity that lives throughout medicine overall certainly is very highly relevant in the brain injury world. And I would argue that even if you're not a trauma surgeon in a major level 1 trauma center, you should care about this for a variety of reasons. Number 1, the public health implications. Okay, fine. But for those of you who've ever moonlighted, worked in a small community hospital on your off hours, and the car goes into a tree right outside the hospital, and you're the surgeon, or you're the person who's standing there, so everybody's going to turn around and look at you. It happened to me when I was a 2nd-year resident. We used to rotate at this tiny little community hospital to do like hernias. Like I was literally there to do hernias, and literally somebody crashed their car into a tree right outside the emergency department. They brought the patient. Everybody turned to me, and I was like, I think I had taken ATLS at that point, but I'm not even sure I had. So the other problem is that most patients who have brain injury don't have isolated brain injuries, right? They have splenic injuries, they have rib fractures, they have all the other things that we need to take care of. And in all fairness, trachs and pegs kind of go with the territory, and we as general surgeons typically get called upon to perform those. And then lastly, it's just not that complicated. Our neurosurgeons, no offense, sir, or our neurointensivists can make it very complicated, and it doesn't have to be, particularly early on, particularly until you get the specialty expertise that you may not possess. It's not that complicated. I do want to go through 2 primary, really important principles about secondary versus primary injury. Primary injury is what occurs at the time of impact. It's impact loading injuries or impulsive loading injuries. So it's the baseball head hits the bat, the head hits the windshield. Those are impact loading injuries. Those are collisions of the head with a solid object at a tangible speed. And then your impulsive loading injuries, which are going to be your acceleration, deceleration injuries. Your diffuse axonal injuries, kids, the shaken baby syndrome is kind of the pediatric equivalent of that. And in 2026, a broken neuron is a broken neuron. We don't know how to fix a broken neuron in 2026. But what we do why we have a job and why we spend all our time and energy is minimizing the effects of what we call the secondary injury. So it's the injury that occurs around that primary injury. It's edema, it's ischemia, it's inflammation, it's apoptosis, it's all these things that occur. And that's trying to minimize or attenuate the damage to that penumbra or that area around the primary injury to maximize function. Because again, what gets broken is broken. We can't do a whole lot about that. These are old. I mean, this is what 93 and 99. It's embarrassing, right? How old these are, but they're still classic studies. Randy Chestnut and Stoketti's data that looked at single episodes of hypotension or hypoxia after brain injury is associated with not only an increased risk of mortality, but an increased risk of poor functional outcome. Definitely a chicken and the egg effect here, right? Whether hypoxia causes worse outcome or patients who are hypoxic have worse outcomes, right? I'm not going to argue with that, but clearly hypotension and hypoxia are bad for your brain. Honestly, if you remember nothing else I would say here today, just remember that. So don't let people be hypoxic, don't let them be hypotensive. And how do we define that? Well, ATLS, the military, the US military clearly defines hypotension as less than 90. Nobody in 2026 thinks that somebody with a brain injury that it's an adult, sorry, I should couch being in a children's hospital. What I'm talking about here is adult parameters. Obviously, we want to use age-specific parameters as we look at younger people and arguably as we look at our geriatric patients as well. But nobody thinks in the setting of brain injury that a systolic blood pressure of 91 is okay. Largely, this is based off of several studies. This is probably the most recent one that basically said there's a cutoff at around systolic blood pressure of 110, that below that level, outcomes are worse. So we typically will target for patients with brain injury, again, adults with brain injury, a systolic blood pressure of at least 110. Again, I would argue younger patients, very different. And then as you get older and normative values increase, right? What's a normal blood pressure for a 75-year-old? 111 is probably not okay for a 75-year-old, your average US 75-year-old, maybe Canadian 75-year-old. And that's what we've gone to, ATLS, PHTLS, and the American College of Surgeons TCO has gone to 110 as our parameter for systolic blood pressure in setting of brain injury. But keep in mind, and I apologize, the writing on that left-hand graph is ridiculously small, but keep in mind that blood pressure that's too high is also not good for your brain. Now, again, chicken and the egg. If you have a Cushing's reflex and you have a higher blood pressure, you have a very bad brain injury, you're unlikely to do well. So some of this is not necessarily that having a higher blood pressure caused you to do worse, but having too high a blood pressure is bad for you. Similarly, having too high a normobaric hyperoxia is also bad for your brain, which leads me to a general principle about brain injury, which is keep everything in the middle of the road. Not too hot, not too cold, not too much oxygen, not too little oxygen, not too much blood pressure, not too little blood pressure, CO2. Stay right in the middle of the road. That's going to be the safest place to be in a patient with severe traumatic brain injury. General rule. The second concept is seemingly really simplistic, and I apologize if this is like you guys are like, why would you even be talking about this? But I can't tell you the number of times where people don't really appreciate what happens in the injured brain and why people actually die from brain injury. And I'll pull up the Monroe-Kelly doctrine for a brief moment in time, let you all have that one synapse in the back of your brain from medical school or maybe ATLS that like, oh yeah, that sounds vaguely familiar, right? Your rigid fixed skull contains things that live within it. If an increase in one of the volume of any one of those three things, largely brain tissue, blood, and CSF increases, the pressure will increase unless the volume of one of the others decreases. Guess what it is? It's compartment syndrome. That's all bad brain injury is. It's compartment syndrome, just like it's compartment syndrome anywhere else. For our orthopedic colleagues in the leg, for our general surgical colleagues in the abdomen, it's just compartment syndrome. And what happens in the setting of brain death is you have neuronal injury, which leads to neuronal swelling, which leads to increased intracranial pressure, which leads to decreased intracranial blood flow, which leads to worsening neuronal injury, et cetera, et cetera. Ultimately, your intracranial pressure is greater than your mean arterial pressure, which is incompatible with life. And the reason I bring this up is there is a subset of patients who are at imminent risk of dying from their brain injury and require an urgent emergent intervention. These are the people, those parameters you see on that left-hand side are the people who are about to die from their brain injury if you don't do something about it. Dilated non-reactive pupils, motor scores of 1 or 2, decrease of GC, a rapid decline in their GCS, and then those people who are manifesting your Cushing's reflex, classically identified by hypertension with reflexive bradycardia, right? The reason you get a Cushing's reflex, it's an entirely normal response to elevated intracranial pressure. Your body's trying to maintain systemic blood pressure. So you get hypertensive. The bradycardia is reflexive to the hypertension. So I can't tell you the number of nurses I have almost tackled in our trauma bay, trying to give atropine to a patient with a bad brain injury who's bradycardic. one of my pet peeves. But these are patients who are going to die from their brain injury if you don't do something. And these are the people that we talk about, like the kitchen sink approach to ICP, like lower their intracranial pressure. You got to do something. Surgery is probably the best thing to do for most of these patients if they have an evacuatable mass lesion, but do something to lower their intracranial pressure. How else can you identify those people in addition to those clinical features? This is a construct that we came up with. I don't know. It evolved in my brain over many years, but I think it's just a nice little way to think about brain injury. For those of you who live in the trauma bay and you could walk over to CT with your patient and you're all standing over the tech's shoulder, staring at this monitor, right, irritating the crap out of them. Everybody's been there at 2:00 in the morning. This is something that you can use to actually detect whether or not your patient has a significant brain injury that is likely to require an intervention. It doesn't mean that they don't have these things, that they're okay. It just means that these are the things that people will die from if you don't intervene quickly. So I talk about 7 spots in the brain. This is some data that one of my fellows subsequently published. If you look at the left-hand side, that's going to be the normal brain architecture. The right-hand side is going to be abnormal brain architecture. And there are literally 7 spots you can look at in the brain. This is one, so base of skull, you want to see CSF around the brainstem. You want to see a 4th ventricle. You want to see that the basal cisterns are open. It looks like a little baby's butt. You want to see the Mickey Mouse ears or the top of the midbrain. You want to see that the lateral ventricles are open and symmetrical. You want to see gray-white differentiation. And then you want to see cell sign gyri at the top of the brain. The younger and healthier somebody is, kids, young adults, teenagers, the less prominent these structures will be. The older and more atrophy somebody has, the more prominent these structures will be. So keep that in mind. But you can actually, while you're standing over there irritating your CT tech, you can actually see what this looks like in real time and say, okay, how am I prioritizing this patient's brain injury? And we actually, subsequent to looking at that, one of my former fellows published some data on this, that if you look at patients who have these features or have absence of these features, they have a much higher incidence of requiring a neurosurgical intervention or dying from their brain injury. It's not surprising to anybody, but it's a really quick, very easy way that I think people can remember to look at the CAT scan particularly for emergency medicine providers, right? They get very used to waiting for the report to come in, and that's precious time when you have somebody who has a severe traumatic brain injury. Who needs a neurosurgeon? And again, apologies to the neurosurgeons in the group. These are the Brain Trauma Foundation guidelines that are now way, way old of surgical management. But these are general parameters that might want to stick in your brain. Again, not waiting for the report to come back, but looking at the CAT scan and saying, hey, when am I going to get neurosurgery involved? Well, neurosurgery, as a general rule, subdural hematoma greater than 10 millimeters or more than 5 millimeters of shift, an epidural hematoma greater than 30 centimeters cubed, and an intraparenchymal contusion greater than 50 centimeters cubed. Huge caveats around this. Pupillary response, what else is going on with the patient, how old or how young they are, what their pupillary response is, what their motor response is. I mean, lots of caveats, but these are, as a general rule, the surgical lesions. In the posterior fossa, all bets are off. Posterior fossa lesions are associated with a much higher incidence of subsequent morbidity. So posterior fossa is a little bit different, but these are the supratentorial lesions that, at least as an emergency medicine provider or as a junior resident in the trauma bay, you should think about, I should get neurosurgery involved sooner rather than later. All right, ICP monitoring. Should we be monitoring patients or not? Hopefully, everybody appreciates why ICP monitoring might be beneficial. We don't want to wait for patients to develop clinical symptoms. Maybe we have to wake them up to do that, which may be deleterious to their injured brain. Relying on CT scan is costly. I don't know if do you guys have any portable CT scans here? Yeah, we stopped. The quality was just not nearly good enough to make any kind of clinical decisions. We stopped using ours. Allowing for elevated ICP, identifying elevated ICP, can allow for more timely imaging and intervention. And then obviously we want to be able to follow patients' cerebral perfusion pressure, which is calculated based on their mean arterial pressure and their intracranial pressure. Well, what does the data say? Level 1A trial, right? Randomized controlled trial, the best TRIP trial done outside the United States. I can't believe this was published over 10 years ago now. It feels like it was just yesterday. That's how you know you're getting old in medicine. You're like, oh, that study that was just published, and it was like 15 years ago, right? But the best TRIP trial, randomized patients to ICP monitoring versus a clinical and imaging-based algorithm. It wasn't that they didn't take care of patients who weren't monitored. It means they just didn't use the ICP measurements to drive their decision-making. And what did it show? You can see on the right-hand side, there no difference in outcome. Lots of issues about generalizability of this study. It was done in Latin America, where ICP monitoring was not considered standard of care. So lots of issues around pre-hospital care and probably as importantly, if not much more importantly, post-acute services, which were basically non-existent in Latin America. And I always tell my families, I'll keep them alive, rehab will get them well. And so I really think this lack of high quality post-acute services is really potentially had a lot of influence here. Interestingly, if you look at the ICP monitored group versus the clinical and radiographic monitored or algorithmic based group, the clinical group actually had more interventions performed: hypertonic, mannitol, hyperventilation, which is kind of interesting. Did anybody know what the monitored group had more of? Sacral decubitus ulcers or pressure injury, right? Kind of interesting because they didn't get them out of bed, right? Because their ICPs were high, so they didn't move them. It's kind of an interesting unintended consequence. But so the best data that would suggest to you is in this setting, should we be using ICP monitoring? It doesn't appear to make a difference with respect to long-term functional outcome. But we all recognize, and the analogy I'll use is, I don't need an A-line to see if somebody is hypotensive, right? I can feel the quality of their pulse. I can look at the turgor of their skin. But God, it makes my life easier if there's an A-line right there, right? But super important to think about what the clinical picture is, what the radiographic picture is, and not just focus on just the ICP in these patients. So let's say we do put an ICP monitor. I mentioned the Monroe-Kelly doctrine, 3 things that live in your rigid fixed skull: brain tissue, blood, and CSF. Very quickly, we'll walk through how you would lower somebody's intracranial pressure, again, in the trauma bay or in the first couple hours after injury. Obviously, if they have a unilateral mass lesion, getting that out is going to be your first line therapy for somebody who has elevated intracranial pressure. No doubt about that. That is relatively intuitive to all of us. Brain tissue, how do we lower that compartment? Well, we have 2 things available to us: sugar or salt, cupcakes or Doritos. People always ask me which is better. I like dessert and I like Doritos. I don't know why we have to choose. Hypertonic saline, this is just a graphic image that shows you a little bit what hypertonic saline does. These are MRIs of rats, mice, rodents of some sort. And the top line there is the bright white is going to be water content as intensity. And you can see before and after the treatment with hypertonic saline, just the decrease in water content, of the brain. This is, again, very old, but I think I like the picture in my brain. Again, which do you prefer, sugar or salt? I don't think it really matters. Multiple studies have been done. No real head-to-head comparisons. Osmolarity is very different in different substances. There are obviously lots of different formulations of 3%. As a general rule, most trauma surgeons like hypertonic saline acutely because we like the volume expansion as opposed to the potential hypovolemia of mannitol. But in somebody who's elevated intracranial pressure, I can support their blood pressure with blood products. I can support their blood pressure with vasoactives I need to. That's where, when we're really in trouble, that's the kitchen sink, mannitol hypertonic. And mannitol works very well. Keep in mind a significant opening of the blood-brain barrier, though, with repeated uses or continuous infusions. So again, 1, 2, 3 doses. Each patient is different how they respond. CSF drainage, as of 6 months ago, I would have said they get an EVD. That's the only way to deal with this. I'm going to come back to this at the end. I encourage you to look at the middle of that slide right there and think about that space, because we'll come back to this with some things that are kind of newer and really interesting. And then the last compartment is the blood compartment, cerebral blood flow. It's why neurointensivists have jobs, is about all that manipulation of cerebral blood flow as a general rule. I shouldn't realize, I say it a little tongue in cheek. But when we talk about reducing cerebral blood flow, there's lots of things you can do. And again, this is where neurointensivists really geek out over ooh, yeah, I can manipulate their cerebral blood flow. And it's kind of interesting, kind of fun, but I argue to you that there are appropriate reductions in cerebral blood flow. And then what I will argue is inappropriate reductions in cerebral blood flow. So if you provide somebody adequate sedation, that causes a decrease in cerebral metabolic rate, which causes an appropriate reduction in cerebral blood flow, right? You're matching their metabolism with their blood flow, which will decrease intracranial pressure by decreased cerebral blood flow. That's an appropriate cerebral blood flow reduction. I will pit that against what I would argue is inappropriate cerebral blood flow reduction, which is the reflexive vasoconstriction and vasodilatation that occurs in response to, for example, hyperventilation, hypoventilation, which is purely reflexive. And if you don't reduce their cerebral metabolic rate, all you get is mismatch, which results in cerebral ischemia, which is why we don't use prophylactic or empiric hyperventilation in the absence of somebody actively herniating. Actively herniating, hyperventilate them, get them to the OR, get their EVD in, whatever you need to do. We'll take care of the ischemia on the back end. But I would argue that appropriate reductions in cerebral blood flow are what you really want to target. Again, I'm not a neurosurgeon, so talking about decompressive craniectomy, all I can really do is tell you what my experience has been with patients I've taken care of, and obviously what the data will suggest to us. Unequivocally, it decreases intracranial pressure. It improves glucose and oxygen utilization. It increases blood flow and decreases cerebral vascular resistance, enhances brain tissue oxygenation, and improves cerebral compliance. Those have been demonstrated. What does the data say? If you really want to get a bunch of neurosurgeons like really riled up, walk in the room and be like, Deborah, and then like carefully back out. DECRA trial was done outside the United States, largely in New Zealand and Australia, I believe. And basically it was a bifrontal decompressive craniectomy that was done after 15 minutes of elevated intracranial pressure. So atypical parameters, atypical surgical intervention, demonstrated worse outcomes in the decompression group. There were some imbalances in the groups. More patients with non-reactive pupils wound up in the surgical decompression group. So lots of reasons why people who take care of brain injury, neurosurgeons take care of brain injury for a living, really felt like DECRA really shouldn't be influencing our care the way it was done. However, the Rescue ICP trial, which was subsequently published, was kind of a more traditional decompression, more traditional parameters for which you then were eligible for the study to be randomized to medical management versus decompression. And I will tell you, there is no surprise in what this showed. Remember, this is compartment syndrome of the brain. So if you have malignant intracranial hypertension, i.e. compartment syndrome, and I just try to manage you medically, what's going to happen? I fail, right? This is the universal sign for herniation, by the way, in case anybody was wondering. What happens is, unfortunately, you developed increased intracranial pressure to the point where you basically occlude your inflow, and those patients die from their brain injury. Or I can do a decompression, and I can remove the skull and allow them to herniate out their defect. So it's more complicated than that. I'm obviously simplifying it significantly, but if you think about it, so fewer patients die from their brain injury if you do decompressions, but of the survivors, a much higher percentage have a poor neurologic outcome because you took a bunch of people who had devastating, terrible intracranial insults and took off their skull and allowed them to herniate out their defect rather than down. So subsequent to that, this group also looked at 24 months. The same findings were true. Surgical patients had sustained reduced mortality, but higher rates of vegetative state, severe disability, and moderate disability at 24 months. But surgical patients actually, interestingly, were more likely to improve over time. So maybe a little bit of an added sprinkle of an added benefit subsequent to that. And again, that was 2 years following their intervention. So what do we do in 2026? And I would love to hear how you guys approach this. It's really all about patient selection. So if you take somebody who has a devastating primary injury or has devastating primary injury and has had devastating secondary injury on top of that, they are unlikely to do well with a decompression. But you take a young kid who was localizing when they came in, had an evacuatable mass lesion, and now has really significant, or I shouldn't say that, has without an evacuatable mass lesion, and now 5 days in has really high ICPs. That may be a patient who might benefit. We, for a while, we had a patient, Dr. Bijan Arabi, who was our full-time neurosurgeon for years, finally decided to retire at the age of 79, I think. I think Bijan's 80 this year. We used to take kids, if they never had a motor score of greater than 3, we would do MRIs before we would offer decompression to see if they had significant secondary brainstem injury. And it's also not the same thing as leaving the bone off, which is a primary decompression. Recent data published on that this is the acute subdural hematoma study that basically looked at leaving the bone off. So this is, again, the functional equivalent of, I have a patient in the ICU who has elevated intra-abdominal pressure. I'm going to do a decompression to treat their abdominal compartment syndrome, a disease we don't see a whole lot in trauma anymore. We still see it in general surgery. Those patients, severe hemorrhagic pancreatitis, that type of thing. Or I took the patient in the operating room. I'm going to leave their abdomen open because I'm worried that they're going to develop elevated intra-abdominal pressure, right? This is the brain equivalent of that. They looked at the primary outcome was GOSE at 12 months, 228 patients in the craniotomy group, 222 in the primary decompressive craniectomy group, and no difference in outcome across the two groups. The only thing that was really different was the patients in the craniotomy group, they had their bone put back on after their evacuation. Many more of them obviously had their bone subsequently taken back off for the development of intracranial hypertension. And there were more wound complications in the craniectomy group, not surprisingly, because those are patients who subsequently needed to have additional interventions to have their bone put back on. So Best data on that is, again, probably about patient selection, which is what you say about most TBI studies. It's all about patient selection. And that's probably been, not to get on the soapbox, the issue with most TBI studies is we tend to lump everybody with a brain injury into one bucket. And that's like saying, what cancer therapy are you going to use? And so thinking a little bit more creatively about how we can stratify patients. And there's, again, I'm happy to talk about that as well. There's some work going on around that. Whatever you're going to do with respect to your ICP management, I would encourage you to be algorithmic, guideline-based. This is just one specific algorithm. I think I'm going to guess you guys probably have a tiered algorithmic system, tier 1, tier 2, tier 3. This is pretty much standard. This is what TQIP has argued for. This is what the Brain Trauma Foundation has argued for. And so this is just one, lots of data that says that algorithmic-based approaches improve outcomes. So before I move on to kind of what's new, briefly, neurointensivists love toys. Apologies to all neurointensivists in the room. Bottom line is outcome studies are pretty rare. Again, this is about patient selection. And so if you just put a cerebral microdialysis catheter in every single patient with bad brain injury, are you going to save a bunch of lives? Our best ability to tell in 2026, no. The one huge exception to that is brain tissue oxygen monitoring. The Boost, are you guys part of Boost? Yeah, Boost 3. So Boost 2, which was obviously the outcome was improved brain tissue oxygen levels, wasn't powered to detect a functional outcome, did demonstrate reduced brain tissue hypoxia, a trend towards lower mortality, and a trend towards more favorable outcomes. And as you guys are familiar with it, being involved in Boost 3, there is currently the phase 3 trial ongoing, which will hopefully help to answer that question of whether or not brain tissue oxygen monitoring, in addition to intracranial pressure monitoring, actually is associated with improved outcomes following bad brain injury. Okay. What's new? Well, this is not super new, but I assume we have some emergency medicine providers dangling out there. I always get asked about pre-hospital intubation or intubation on arrival, who should be intubated. This concept of if my residents toss around the term protect the airway one more time without actually knowing what that means, well, they're not protecting it. What does that mean? It means that you have loss of oropharyngeal reflexes. You have to be pretty comatose to lose your oropharyngeal reflexes or have bulbar dysfunction from some sort of stroke. But we talk about the pros of, and I put in pre-hospital and kind of like slash intubation on admission together. The pros of doing that is you can stay right in the middle of that road, right? Not too much oxygen, not too little oxygen, not too much CO2, not too little CO2. If they are herniating, you can hyperventilate them. You can, I have to change, sorry, that did not say prevent aspiration. We all recognize that endotracheal intubation does not prevent aspiration. It decreases the risk of macroparticulate aspiration. But there's a bunch of problems with intubation, particularly in the field, particularly with inexperienced pre-hospital providers. Are you guys an aggressive intubator pre-hospital environment? Like in Seattle, everybody gets intubated in the field. It's fascinating. Like everybody. Baltimore, we're kind of 50-50. But there's some real risks. And the ones that are very practical from a trauma surgeon perspective is you just gave them a bunch of RSI drugs. I just lost my exam. And number two, you just put them on positive pressure ventilation. And if they are also hypovolemic from hemorrhagic shock, you just made them more hypotensive, right? We've all taken care of the patient who comes in with bad hemorrhagic shock. As soon as you push drugs, they arrest, right? Patients with brain injury have hemorrhage too. So that's a real problem for us. And the other thing is this, and I talked about hyperventilation, empiric hyperventilation being bad for your brain. This is just looks at survival versus CO2 levels. And what you can see is if you hyperventilate somebody, they do worse. If you have too high a CO2, they do worse. So again, it's about that sweet spot in the middle. And some of the early studies that looked at empiric intubation for patients with brain injury showed worse outcomes because of this. Because what's the first thing you do when you intubate a patient successfully, particularly if you're not super experienced and you're a pre-hospital provider, is you hyperventilate them. That's what I would do. Oh my God, I got the tube in. That's exciting, right? Additionally, there are two observational studies that basically demonstrate if you take patients, this was one study that takes patients with GCSs of 6, 7, and 8. The next one I'm going to show you is just 7 and 8, that showed patients who were intubated on arrival, so immediately on arrival, had an increase with these GCS levels, had an increase in mortality, longer ICU, longer length of stay. So that rule of everybody who has a GCS of less than 9, i.e. severe traumatic brain injury, has to be intubated, challenging that dogma. This is, again, that second study I mentioned. This was looking at 2,700 patients. And again, this is patients with GCSs of 7 or 8 and had worse outcomes with immediate intubation. And this is an expression I use all the time. And I was really pleased to see that this showed up in the newest version of the pre-hospital guidelines for management of severe traumatic brain injury from the Brain Trauma Foundation. It's not about intubating the patient. It's about managing their airway. So it's maintaining appropriate oxygenation, appropriate ventilation. You don't necessarily need to stick an endotracheal tube in. If you're going to, please make sure you maintain normal CO2. That's the rule about that. Penetrating TBI, mine and Dylan's favorite topic. What, 2 years of our lives we devoted to this? 3? This was published. We are. I'm very proud of this. I hope you are too, Dylan. Dylan and I think we were the only 2 trauma surgeons. Yes, in a room full of very scary neurosurgeons. They had a lot of feelings about a lot of things. I encourage you, if you get a chance, please take this QR code. This gets you right to the Brain Trauma Foundation guideline website, and all the guidelines are there. They're all free. It'll show up in a bunch of slides. But please go there and take that content, distribute it widely. That's what we're all about. We did look at when we redid the penetrating TBI guidelines. The previous ones were from 2002. And so this was a Herculean effort. And obviously attempted to make evidence-based recommendations whenever possible. For those of you who've spent some time in the penetrating TBI literature, you will recognize that there weren't any level 1 recommendations. I think there were 2 level 2 recommendations, a smattering of level 3s, a smattering of level 4s, and then a whole lot of what we called tiered level C, which was expert opinion. And trying to make these guidelines clinically relevant as rather than just, because it just isn't data for most of these things. One of the things that came out of this that I'm very proud of is that there were a series of treatment algorithms that were associated with the evidence-based guidelines. This one was kind of my baby that I took some shots for, which is this futility assessment toolkit. I said to the room, and Dylan can verify this for me, can you guys just tell us who are the patients you're not going to offer an intervention to? Everybody in the room, and this was a room full of the most aggressive neurosurgeons you will ever see, about specifically around traumatic brain and around penetrating TBI. And the issues around nihilism and around allowing our trauma colleagues across the world to say, oh, they have a gunshot wound to the head, therefore it's not worth intervening, was so palpable in the room. People were terrified. And it happens, right? We've all seen it. It happens all the time. And so what I wanted to try to get out of them, what we worked on was, what are the features that make you say, you know what, this is not somebody who has a salvageable brain injury, as opposed to this is somebody who, I don't know yet, right? I can't tell yet. So we should keep going until something declares itself. So again, these are all freely available with this QR code, braintraumafoundation.com.org. I don't even know. I want to go through a couple of the ones that are more relevant for what we do as trauma providers. This is one that, again, was very near and dear to mine and Dylan's heart. Is the role of CTA, DSA, and the timing of those imaging studies. For those of you who aren't aware, there is actually a relatively high, I should know the number, and I apologize for not, of incidence of intracranial aneurysms associated with penetrating brain injury, obviously vascular injury. So this is one of the very few level 2 recommendations in the guideline that says DSA should be performed as soon as feasible following brain injury. Level 3 recommendations following brain injury, the detection of traumatic intracranial aneurysms by screening improves the likelihood of survival. CTA should be used as your initial screening modality. And then vascular imaging, I don't know what I did there, should be repeated at some point following injury. And I will freely admit my institution does not do that very well, but the recommendation, which you'll see on the thing on the next page, is that it be done sometime prior to discharge, is that even if their initial imaging is negative, that you repeat that imaging, because delayed intracranial aneurysms are associated with a very high risk of morbidity from rupture, obviously. High clinical suspicion for vasospasm, DSA should be considered over CTA. DSA should be obtained in cases where the vascular injury cannot be ruled out. It's largely because of streak artifact. And DSA should be used in all patients who have confirmed vascular injury. Timing, we don't really know. As a general rule on admission, they should have some imaging. And then again, prior to discharge, some additional or secondary imaging should be done. If you can't rule out intracranial vascular injury with CTA, then DSA is recommended. Our protocol is patient comes in with a penetrating gunshot wound to the head. They get a CT scan, dry CT, plus a CTA just on admission. We just do it empirically now, and it does really help guide your subsequent decision-making. ICP monitoring, again, a level 3 recommendation should be managed using ICP monitoring to reduce mortality. ICPs should be maintained below 22. That's identical to the blunt trauma literature. Seizure prophylaxis, anti-seizure prophylaxis indicated for 7 days or longer. 7 days is what most of us would advocate for, although there is a subset of patients, again, patient selection, for whom you might choose to use longer prophylaxis. Again, this is not treatment. Patients who seize get treatment. This is pure prophylaxis, but no specific anti-epileptic drug can currently be recommended. Antibiotic prophylaxis, another very hotly contested topic. As a general rule, it's reasonable to treat patients with penetrating TBI who have violation of their dura, who are undergoing invasive procedure with some prophylaxis. There's a subset of patients who are at highest risk. That's going to be like your sinus penetration, significant retained bone fragments, who you might choose to do a longer duration, i.e. up to 5 days. But as a general rule, most patients should probably get 3 days. Again, this is all consensus statements, not evidence-based. And if you're going to use antibiotics, you should do it as soon as possible. Again, no big surprise to any of us that do this for a living. VTE prophylaxis, was really pleased to see this statement. Basically, the summation of a lot of words on this page here are that that most patients can probably get pharmacologic prophylaxis within 24 hours of stable imaging or of intervention, which is revolutionary for some centers, particularly in the United States. I don't know what your protocol is here, but I mean, I have people call me like, my neurosurgeons won't let me give anything for 2 weeks still in 2026, which is a little against the league. As I like to say, let's not let data get in the way of a good opinion. This is just some highlight from the executive summary that we published. Again, I apologize for the teeny tiny words on this page, but just to show you that we put a chart together that shows you the big differences between 2002 and 22 years later when the next version was published, hopefully a little bit modernized. I would also encourage you to go to this website. There's a really cool toolkit there that you can use, probably less relevant for those of you that live in level 1 trauma centers and do take care of patients with brain injury for a living, but certainly for our colleagues out in the community, a patient shows up, how am I going to take care of this patient? You basically put in the clinical features and it brings you to the relevant section of the guideline to help guide your management. So super helpful if you're at a level 2, level 3, level 4 non-trauma center somewhere and somebody happens upon your door. Really nice tool that you can potentially use to help kind of guide that initial management of that patient. All right, moving on to talk about transfusions. Again, as a trauma surgeon, transfusions are like one of the things that my non-TBI life is all about, like blood loss and hemorrhage and that type of thing. So how do we transfuse patients? Well, everybody is aware that the standard of care would suggest to you that hemoglobin greater than or equal to 7 is how we take care of patients, critically ill patients globally, but also patients with brain injury. Does anybody know where that comes from? The TRIC trial. The older people in the room are like, yeah. The younger people in the room are like, what are you talking about? This was the TRIC trial. This was the trial that said, we used to, when I was a resident, because I'm old, we used to transfuse everybody up to a hemoglobin greater than 10, right? Because the delivery equation, I won't torment you too much with that, but we used to transfuse everybody. They had to have a hemoglobin greater than 10. That was what we did. The TRIC trial was published in 1999. And demonstrated that patients who were transfused, particularly the less sick patients who were liberally transfused, i.e. a transfusion trigger of greater than 9, as opposed to 7, did worse because of infectious complications. You know what else was popular in the 90s? A little smattering of like fun little things. So a group from Canada asked really, really important question about, is this still true in 2020? I guess they probably started the study in probably the 2017, 2018, and asked this question, really important question. Is a restricted transfusion strategy still appropriate in 2025? Well, that's when it was published. We now universal leukoreduction of blood products, and there's significant advantage in blood product storage, right? The blood that we used to transfuse in the 90s is not the blood that we transfuse in the 2020s. It's just not. Is it generalizable to patients with neurologic injury? The TRIC trial did not include a lot of neurologic injured patients. There certainly wasn't a subset analysis that says that clearly restricted transfusion practices are better. And is that true specifically for traumatic brain injury? So this is the HEMOTION trial. This was published 2 years ago now. And they asked the question of, in adult patients with severe traumatic brain injury, does a liberal transfusion strategy, i.e. greater than 9, 10, versus a restricted transfusion strategy, what we currently do of greater than 7, does it result in differential neurologic outcomes? Again, this was done in Canada, the UK, France, and Brazil. Apologies for the many, many words on this slide, and I should have cleaned this up for you guys, but 73% of patients had severe traumatic brain injury. The median GCS score in both groups was 4. The median ISS was 30, so these are significantly injured patients. 65% of them had polytrauma. And what you can see, and again, what you probably can't see because the writing is way too small on these slides, my apologies, I can't see on here either, is of the patients they enrolled, There were some imbalances in the group, which are maybe important, but basically the bottom line of the New England Journal article said no difference. However, if you really look into the data, and this is probably the most illustrative part of this study, is that if you look, the gray squares, the gray black are people who died. That orangey color is like did poorly neurologically, and then those brighter colors up to the blue are people who did okay. So it was not statistically significant, but if you look at FIM scores, quality of life scores, there's something here. They're in the process. This is all frequentist analysis. They're in the process of doing their Bayesian analysis now. So a lot of people are really, really looking forward to seeing what that looks like. Subsequent to that, around the same time, the TRAIN trial came out. The TRAIN enrolled patients who had subarachnoid, non-traumatic intracranial hemorrhage, and traumatic brain injury, and demonstrated improved neurologic outcomes. And these were patients with isolated traumatic brain injury. And I think I have it. If you look at the TBI group there, you can see that bar kisses one, like literally kisses one. So I actually think that technically the p-value for the TBI subgroup was not actually significant, but let's not let our opinion get in the way of our data. So I think that we need to think a little bit differently about patients with brain injury in 2026. What about plasma? Transfusing plasma? Well, there's some animal data that demonstrates that this is just one of many studies that demonstrates when you give animals who have brain injury plasma, they do better, both neurologically as well as from a contusion development perspective. Well, there's some human data that actually supports that, and this is a subgroup analysis of the PAMPER trial. PAMPER was empiric plasma administration to patients with hemorrhagic shock in the pre-hospital environment. So this was a hemorrhagic shock trial, but they looked at a TBI subgroup. You can see 166 patients of the 501 who were enrolled. And the provision of pre-hospital plasma in patients with severe traumatic brain injury was associated with an increased survival. So really interesting. Why is this? It's something having to do with this. I'm not a basic scientist. That's apparently the glycocalyx. It apparently has something known as syndecan. It is apparently very important to maintain this to prevent inflammation and bad things from happening to your body subsequent to injury. My good friend and colleague and partner, Rosemary Kozar, can tell you all about this. Please invite her. She gives a wonderful talk on this. But it has something to do with, there's something in plasma because your coagulation and your inflammatory systems are so intertwined. There's something that's in plasma that helps to maintain the endothelium and that really minimizes the risk of subsequent secondary insults, like we talked about, and subsequent secondary complications. So that's probably what plasma is doing as much as it is helping to reverse any developing coagulopathy. What about TXA? Do you guys give TXA in the pre-hospital environment for brain injury? Yeah. So again, it's obviously an antifibrinolytic. It obviously inhibits tissue fibrinogen activator. There's something else going on there that's similar to plasma that probably helps patients with brain injury in addition to patients with hemorrhagic shock. This is the CRASH-3 trial. CRASH-2 was TXA for hemorrhagic shock. CRASH-1 demonstrated that steroids in brain injury were bad for you. So the only level 1A data that exists in traumatic brain injury that demonstrated a clear differentiation. CRASH-3 was TXA for TBI in the pre-hospital environment. Again, the same deal within 3 hours of injury. What's really interesting is that overall it demonstrated benefit. But if you look at the patients who had the GCS of 3 to 8, wasn't really a benefit. And again, those patients who had non-reactive pupils, no benefit, in fact, potential detriment. So again, it's doing something there that probably isn't necessarily just making you not antifibrinolytic. There's something about TXA. Subsequent to that, this is Susan Rao's data from the United States. Again, they gave patients in the field. The bottom line conclusion of this study in JAMA was no difference. However, when they looked at a subgroup of patients who got 2 grams of TXA, those patients had an improved 28-day mortality, which has led a lot of US trauma centers, I'm going to guess probably Canadian and certainly military, because of the influence of some of these authors, to say that 2 grams of TXA should be our standard of care. There's probably a little downside. With the exception of this was data out of the UK, out of Europe that demonstrated an increased mortality with the use of TXA in patients who had isolated severe traumatic brain injury. So I don't know what to do with TXA in the field. I don't think there's a huge amount of detriment. I think you have to practice where you practice. So what are your pre-hospital transport times like? You guys? Yeah. Right, it's either 10 minutes or it's 3 days, yeah. Yep. Yeah, so same with us. So when I was in San Francisco for a couple of years, 8 minutes was the median pre-hospital transport time, right? You couldn't even draw up and administer TXA in 8 minutes, right? In Baltimore, the same thing. We're very dichotomous. It's either local Baltimore City stuff or it's stuff that's coming from, we're not, our catchment area isn't nearly as big as yours, but it's stuff that's coming from all over the state. So 45 minutes is our average pre-hospital for our people who come in from non-Baltimore City. So again, there's a smattering. If you don't have a whole lot else to do for somebody while they're in the field, giving TXA is probably reasonable. I'll leave it at that. This is what I wanted to get at with respect to CSF drainage, and for my huge apologies to the neurosurgical people in the room. I had never heard of this in my entire life, and this just came up as we are in the process of diving into the fifth edition of the blunt severe traumatic brain injury guidelines for the Brain Trauma Foundation. But cisternostomy, it's an opening of the basal cisterns to atmospheric pressure to help reduce intracranial pressure. It's performed as an adjunct to decompression or as a standalone procedure. It is very, very prominently used in what we call high incidence environments like India and China. I'll just show you the picture. Again, apologies to the neurosurgeons, but you have to be able to identify these structures. The sphenoid ridge, the orbitomeningeal band, the roof of the superior orbital fissure, the optico-carotid window, the carotico-oculomotor window, and liliquist membrane. And I realize if you're a neurosurgeon, you're probably like laughing at me right now, but I'm like, I don't know where those structures are. I don't. I know they're somewhere in here, but that's as best as I can do. However, and I would love to hear from some of our neurosurgical colleagues whether or not this is something, kind of opinions about this, but if you think about the brain embryologically folds upon itself, you basically unfold the brain to get into that space. These are just some images. To me, they look like vocal cords. Those vocal cords are in fact your optic nerve and your internal carotid artery, apparently. And you need to go right between the two to put that tube in for a cisternostomy. This is what blew me away when I started looking at this, when I heard about this. So this, on the right-hand side, this is an observational study of 19 versus 24 patients, but improved ICP control in the cisternostomy group over the decompressive craniotomy group. And if you look on that left-hand side, this is in Nepal, 284 patients in the decompression group, 272 in the decompression plus cisternostomy, 476 patients in the cisternostomy group, and look at the mortality rates across those three groups. Really, really interesting. This is the only randomized controlled trial that is available. It's 25 patients in each group, so please take these data with a huge grain of salt. And what you can basically see is those patients who had severe TBI, those patients who had cisternostomy did better from a GOSC perspective than those patients who did not. Then again, 1.4 versus 2.56. So, but really interesting and something that for me as a US focused, never look outside my own four walls, right? Very classic American. I was like, whoa, wow, this is like a whole thing. So I would love to hear some neurosurgical opinions about that. I will finish with just some commentary, because this is why I love taking care of patients with brain injury, is that it's not just about the brain. It really isn't. TBI is very much a multi-system disease. If you go back to now the early 2000s, 89% of patients will develop dysfunction of at least one non-neurologic organ system. In all fairness, that was back in the high crystalloid days. More modern series demonstrated an incidence of about 30%. So about a third of patients will develop significant non-neurologic organ dysfunction. And those patients obviously do significantly worse, which is why it's so important for us to think about these patients not as in isolation, like they're not a head in a box. And think about all the therapies that we talked about: hypertonic saline, mannitol, propofol, right? All hyperventilation, all of these things are systemic therapies that you're applying to this patient. So the mantra, like I'll like be in the corner doing this, like, arguing myself, saying this to myself, protecting the brain while managing the rest of the patient, but also protecting the rest of the patient while you're managing the brain. I will finish with that. Hopefully I left enough time for questions. I thank you guys so much for the invitation and the opportunity to be here and your attention today. Thank you.
Thank you so much for that insightful and practical talk, as well as being perfectly timed. Dr. Stein, are there any questions for our
Who says
admitted
I can't get
speaker?
through 109 slides in 45 minutes?
Go ahead, please.
Thanks very much. Neil Lipsman, neurosurgeon at Sunnybrook. Avery told me I can't miss this talk because it would be so excellent, and he was absolutely right. So that was a real tour de force. So really outstanding, and I would have loved it if our residents and trainees were all. So I'll just make one comment. I'll take the microphone privilege and then question for you. First of all, I, as a neurosurgeon at Sunnybrook, am incredibly privileged to work with some of the best intensivists and trauma surgeons really anywhere. So I think the people of Ontario and Toronto are really lucky, and I wouldn't be survived if our survivals are better than others, just because the people in the city are just outstanding. We benefit hugely from open lines of communication with our colleagues. Heterogeneity is something that plagues the field for sure, and I think arguably more so than really virtually any other subdiscipline of neurosurgery. Can you comment at all on whether the emergence of biomarkers in the brain, GFAP, NFL, et cetera, can potentially help us stratify which patients may benefit or not from an intervention? What we can do there?
Yeah, it's a great question. So there is a new, what's the word I want to use? There's a new rubric for assessment of brain injury. I forget the acronym. I should know, and I apologize. There's an acronym for it. Jeff Manley has led a lot of these conversations. There was a big group that I was fortunate to be part of at the National Academy of Science that was looking at this. And it's basically saying, right now we define severity of brain injury by GCS, which is we all recognize is ridiculous. And so what they have done is create a rubric whereby you use clinical features, pupillary response, radiographic findings, and biomarkers to actually stratify patients. They haven't kind of figured out what the stratification looks like yet, but they've identified what the features that should go into that stratification that could be used, number one, for prognosis, right? Which obviously is a whole other topic of conversation, but number two, and probably more importantly, to actually stratify patients for eligibility in different clinical trials that address different parts of brain injury. Because to your point, I could not agree with you more. It makes me crazy that we treat a kid who comes in with a GCS of 3 with fixed non-reactive pupils the same way we treat a patient who comes in with a GCS with a motor score of 5 with a unilateral, with a big subdural hematoma that we can evacuate. It's just a very, to your point, huge amount of heterogeneity. And so hopefully that rubric, that stratification will allow us to more precisely identify which patients would benefit from which interventions, and biomarkers are a huge part of that. That being said, I think that there's some pushback because it starts getting really complicated. And when you do research, for those of you who've either spent time as a research coordinator in a trauma bay and tried to enroll a patient within the first 10 minutes of intervention, because we all recognize the earlier we can intervene, the better off we're going to do, it gets really complicated. So trying to figure out the happy medium between enrolling the right patients who have the right type of disease and the right type of trial will be the only way we'll be successful. So thank you for bringing that up. It's a super important point.
Cysternostomy, not a thing in Canada. Canada, at least.
I literally had never, I've been taking care of patients with brain injury for 25 years. I literally had never heard of this. And this came up in our global
I had
surgeons.
never heard about it either.
Yeah, apparently the surgical procedure, and please correct me if I'm wrong, is really pretty specific and done by vascular neurosurgeons and microvascular. It's a microvascular technique.
Yeah.
It looks terrifying. Yeah. As somebody who operates on the heart, it looks terrifying. Yeah.
Thank you.
Thank you.
Yeah, thanks very much. Another neurosurgeon here. So I really enjoyed your lecture. Thank you. And in respect to what you mentioned about Jeff Manley, who was just here, he talked to us and gave us the data about the biomarkers, which Nir mentioned, but also CT indicators. And you mentioned the 7 CSF spaces that you can pick up. You can pick them up. I can pick them up. Nir can pick them up. But a lot of folks in the room won't be able to see what's there. But the AI generated interpretation now of a CT scan will do that in a second. And that's maybe what's going to be needed to help identify those prognostic indicators on CT. But more importantly, MRI, which you mentioned. We have to get MRs on these traumatic brain injured cases because it's going to show you way more than the CT scan is, right? That has to be, I think, one of the next steps.
So for the first comment, I could not agree with you more. I think that it's interesting. I don't know. AI is reading all of our non-traumatic ICHs now in my hospital. It actually spits out an automatic report, and there's also one that's generating an automatic Tiger. It's our internal system, automatic text to our stroke service when patients come in for detecting stroke as well. We've not we have not extrapolated that to brain injury, but to your point, I could not agree with you more. I think that of all the subspecialties of medicine, radiology is the one that's really going to benefit the most from, maybe not for the radiologists, but from a patient care perspective, is really going to benefit the most from AI. I could not agree with you more. From the second thing, MRI, so you're speaking my language. I think what we started having a lot, no offense to the neurointensivists in the room, we started having some like card-carrying neurointensivists in our neurotrauma unit, which we had never had prior to that. And we did notice our outcomes our outcomes are good too, right? But we had a huge increase in the number of MRIs we were doing. And I think that this is my opinion. There's lots of things about MRI, functional MRI, for example, tractography, super interesting. I don't think we know how to apply what we're seeing clinically yet. But there is nothing that makes me more crazy than a kid who's eating a cheeseburger, but he has DAI on an MRI. And you're like, so I personally use MRI in patients who are clinically doing poorly as an adjunct for my conversations with the family, because I do think pictures can be helpful. But if somebody's clinically doing okay, the MRI is not going to change what we're going to do. Now, there are some specific reasons why you might choose to get MRI. So again, I'm not an MRIologist, but I'm also, the knee-jerk reaction to getting an MRI for every single patient who has a brain injury, irrespective of how they're doing clinically, I think is not particularly helpful. That it's probably not super detrimental other than from a research health expenditure perspective. But I agree with you 100%. Yeah. Thank you.
We've got a question for you from our online joiners. Dr. Jenkinson, who's one of our orthopedic surgeons, is wondering, sort of recognizing that TBI patients are multi-injured patients, how can we best plan the timing of other needed interventions for these patients, such as fixing long bone fractures, pelvic fractures, et cetera?
Yeah. So thank you so much for that question, because the thing that really like keeps me up at night is this concept of managing brain injury in the setting of polytrauma. In fact, I was just bugging Dylan about helping me out with some guidelines on that exact question, orthopedic injuries being one. I think there are two things I say about that. I think one is that the failure to appreciate the broken extremity, the broken long bone, particularly as an immunologically active organ, is really problematic. Unfixed fractures make people sick. There's devitalized tissue that needs to be debrided. There is just the bone marrow does not like being exposed to the world. It just really gets very unhappy about that. And so putting very much in the construct of prioritization, fixing particularly long bones. Pelvic fractures are a little bit of a different animal because I always say to my fellows and residents, there's no such thing as a contraindication. There's just a really bad risk-benefit ratio. And so as you think about these individual decisions of when is it okay to fix a fracture, you have to put in context what the risks of fixing that fracture are versus the benefits. So femur fractures, throw the frame on as early as you possibly can because their ICPs are only going to get worse, right? Fixing an acetab and losing 2 liters of blood and having them be hypotensive up on their side when you can't put them in Trendelenburg or in reverse Trendelenburg and manage their ICPs as easily, you might choose to make a different risk-benefit decision. So yes, fix long bones, get a frame on them. If you don't want to do definitive fixation, fine, just get a frame on them so they stop moving and they stop creating additional immunologic insults to the patient. But some of the more complicated repairs that our orthopedic surgeons need to do to maximize function, those probably are better delayed. And so a lot of this has to do with who your anesthesiologist is. I have some anesthesiologists. We do a lot of resuscitation in the operating room, but some of this is positioning problem. When somebody's up on their side to get their acetab done, there's not a whole lot you can do for their ICPs, right? As opposed to fixing somebody's both bone forearm fracture where you can do it that sitting up. So thank you for the question. It's super important. I don't think we have the evidence-based answer, but certainly thinking strategically about those individual risk benefit. And that's why I think it's really important that somebody who understands the disease of trauma is kind of steering the ship for these patients, as opposed to people who are just looking at their part of the body. With the classic example is the patient who has the aortic injury and a bad brain injury, right? The neurosurgeons want the CPP greater than 60. Your vascular surgeons want the systolic blood pressure less than 90. I'm sorry, but I can't do both those things.
Thank you. We'll take one final question there. Okay, fine. 2 final questions.
Thank you so much for a very impressive talk. I'm actually in research in neurotrauma, but mostly spinal cord. And one of the things that we see is that the average age of the patient who presents with neurotrauma is much higher now because of population aging. And I'm just curious to know, how does that impact traumatic brain injury and its management?
You guys are asking such a good question. So I'm happy to come back and talk about geriatric traumatic brain injury. It happens to be like one of my little pet projects. In fact, it has a huge impact, and there are a bunch of issues around and I would actually argue pediatric brain injury and geriatric brain injury are completely different than what I just talked about. They require a whole different set of research questions, and they require largely a significant. We need to approach those patients very differently. And I brought up in the very beginning the issue of blood pressure management as just one example from geriatric brain injury. A blood pressure of 111 is not okay for grandma who normally lives at 170, right? It's just not okay. So that's one kernel of where it's different. A second one, for example, would be things like patients who have significant cerebral atrophy don't manifest elevated intracranial pressure, right? Those patients will be fine, and then they fall off the cliff when they rebleed, rather than slowly become a little bit confused, a little bit lethargic, like your young, healthy person who has a nice plump brain does. So you're absolutely right, completely different disease. Geriatric spinal cord injury is another, happy to come back and talk about that. It's a whole other thing as well. And we also know there's a huge component of nihilism in that patient population, which is devastating, because if you say somebody's going to do poorly, they do poorly, right? Especially as you have conversations with family, but you need to balance that with being goal concordant in our care, right? What we don't want to do is do things to people, not for people. And so figuring that out, I wish that everybody could have a conversation with your mom, grandma tonight to say, what would you want us to do for you? Because I think that's one of the big issues is goal concordance and making sure that I'm going to see my parents tomorrow. I think I'm going to have a conversation with them. It's going to be very awkward. Thank you for asking that.
All right, we would love to ask you questions all day long, but unfortunately for the sake of time, we'll wrap up here. Please join me in thanking Dr. Stein for being here.
Thank you, guys.
We have a few things.
Thank you. Thank you so much.
Thank you, Dr. Michelle. I know.